Perfect. And Laura, we met already. This is Abby Steiner. I'm also an epidemiologist here at Denver Public Health.
And this is Melissa McClung, also an epidemiologist at Denver Public Health.
And so can we have the folks on the phone try and make it through some introductions?
Hi, Emily. This is Lauren Ambrosic with the Colorado Prevention Alliance.
Hey, Lauren. Thanks for joining us.
Hi, this is Mary Jo Strobel. I'm with Kaiser Permanente, but I am participating today as a member of the Colorado Prevention Alliance.
Super.
Hi, this is Lindsay McIntosh. I'm Executive Director at Consortium for Older Adult Wellness, and we developed Workshop Wizard.
Anyone else on the phone?
Hi, this is Becky Diorio from the Colorado Department of Public Health and Environment.
Great.
Hi, this is Nadine Chambers from the American Medical Association.
Hi, this is Sarah Strong from University of Colorado Denver School of Public Affairs.
Hi, this is Sissy Kraft from Anthem.
Hi, this is Alea
Paulson from the Center
Levi-Sally.
for
I'm
Improving
calling
Value in
from Kaiser
Healthcare.
Permanente.
Sorry, I don't think we got those two, you guys. Could we have you introduce yourself one more time, the last two who just went? I just didn't catch those.
Sure. This is Alea Levi-Sally. I'm calling from Kaiser Permanente.
Super.
And this is Kristen Paulson. I'm calling from the Center for Improving Value in Healthcare here in Denver, Colorado.
Great. Is there anyone else on the call who hasn't introduced themselves? Okay, super. Well, that's a great audience. I'm really glad everyone can join us. And as I mentioned before, we'll record this and can follow up with anyone offline. I know there were some folks who were out of town today and couldn't make it. So just to provide Laura a little bit of additional information, she had done a demo for Denver Public Health on a webinar just like this maybe 5 or 6 months ago when we were thinking about how we could expand what we know about e-referrals that we were doing for the Quitline. And Laura, just so we provide you good context, we've made a lot of progress, and there's been some additional investment by the State Health Department to explore e-referral for diabetes. And so that's one of the reasons there's a much wider audience on the phone today, and we're excited to see the demo of Mass Highway.
And one more thing, Laura, there's an option to share to make your screen full so we won't see your menu bar at the bottom. And if you kind of move your mouse to the right side of your screen, there should be an option if you go all the way up to the top. No?
Let me.
Don't worry about it. Oh, there you go. Thanks. Perfect.
Let's see if that works. Okay, great. So thank you for tuning in today. I know this has been a long time in the works. I have several people in my office with me here in Massachusetts, and I'll let them introduce themselves. But first, I'm Laura Nasuti. I work at the Massachusetts Department of Public Health and have been with the e-Referral program since the Massachusetts e-Referral program since it started in 2013.
Hi, I'm Michael Stelmack. I'm the e-Referral System Manager.
Hi, I'm Daniel Wegline. I'm an epidemiologist that joined the team about 9 months ago, and I'm the project lead for eReferral.
I'm Alice Bird, and I'm the eReferral program coordinator.
So I've asked everybody to be in the room today because as eReferral has grown, we've needed people to wear different hats for different aspects of this program, and so we're well equipped to field any questions, as well as equipped as we can be, I guess. And with that, I have a couple slides to go through an overview of the program. I recognize several of the names during the introduction, and so for some of you this might be a little bit repetitive, but hopefully there's some new information. And then we will do a demonstration using our test environment. And so with that, I just want to talk about how the program started. So we were able to launch this project through a State Innovation Model Testing Award. We received the award in 2013, and the Department of Public Health proposed a project to create an open source bidirectional referral system. And what we meant by that is that clinical sites were going to be able to send referrals from their electronic health record to community-based organizations and actually receive feedback reports on what was happening and if those services were being received out in the community. At the same time this was happening, we had a prevention and wellness trust fund that was starting in Massachusetts. That was $57 million to go out to 9 partnerships across the state. Those partnerships were made with, they were multi-sectoral partnerships that included clinical organizations, community organizations, and often municipalities or insurers or other non-clinical, non-community-based organization entities. And one of the big drives in the Prevention and Wellness Trust Fund was to actually be forming community clinical linkages and having the clinical sites refer patients to community-based programming. And so it made sense to align e-referral with the Prevention and Wellness Trust Fund. So that gets me to my third bullet point, which is that originally when we submitted the grant, we proposed to really, in the first year, launch in 3 clinical sites, handhold those clinical sites, talk to them about what was happening, learn a lot about the process, and then each year add another 3 clinical sites and really do this slowly and thoughtfully. What happened, because we joined with the Prevention and Wellness Trust Fund, is that we instead went really fast. And we have 11 clinical sites that are enabled to send referrals from their electronic health record, and that's to 12 community-based organizations. We have an additional 5 clinical sites using the eReferral gateway, which is actually what we'll be demonstrating today. And so this pilot quickly grew to a little bit more than a pilot. But as background, what is it? And so this is our bread and butter slide here, which shows you at a very high level what's happening during the e-referral process. So we have somebody at a clinical site that is screened in this example. It's for falls. We have a lot of falls work going on through the Prevention and Wellness Trust Fund. And so here, a healthcare provider finds a patient at risk for falls and wants to refer her to a community-based organization for a falls home assessment. The referral leaves the electronic health record after getting consent from the patient with a couple key pieces of information, but minimal information, the minimal necessary to act upon the referral, and that information gets shuttled to the community-based organization. The community-based organization is able to log on to our e-referral gateway and contacts the patient, calls her, sees if she's interested in the service, sets up a visit, and is then able to actually send feedback reports to the clinical site about what happened. Now, this is the general workflow at a very high level for all of our e-referrals. What changes referral to referral is the necessary data elements to act upon a referral, and the feedback reports and the frequency of the feedback reports that are received. This, for in case we have any technical folks in the audience, this is as technical as we're going to get on a slideshow, but we have Michael Stelmack here to answer more technical questions. But the basic gist of this slide is that we have worked with, to date, and developed integrations with 4 electronic health records. You can see them on the left. these are the 4 because of who is participating in our eReferral visits or eReferral pilots today, as well as the Prevention and Wellness Trust Fund. NextGen and eClinicalWorks in particular have heavy use in Massachusetts among the community health centers. So we have messages successfully leaving these electronic health records. They go to the highway, which is our state health information exchange. So all the sites on the left need to have a highway connection. They send the data through our state health information exchange, and that e-referral system actually translates that so that community-based organizations can see the data on the e-referral gateway. And then we are working on a couple connections where the data gets sent directly to, say, a tobacco Quitline database. These are some of our current referral types. As I mentioned earlier, we have a lot going on around falls. We also have a lot going on around diabetes prevention programming, in part due to the CDC's state and public health actions to prevent chronic disease, or 1305 and 1422 grants for some of the people in the audience who might be working with those grants. And then at the bottom on the right hand, you can see that we also have a referral to Meals on Wheels. We are also working on other types of social service support connections, like through Health Leads, which is a nationwide organization, but we're working with a group in Boston where the referrals would go to Health Leads for different things like utility assistance and food assistance, job training, and the Health Leads counselors would help figure out the right resources for the individual patient or client. So as of June 30th, I mentioned earlier the number of clinical sites. We have about 1,800 referrals and over 2,000 feedback reports. The disconnect between the number of referrals and the number of feedback reports is because depending on the site, you can have multiple feedback reports depending on how much information the clinical site and the community-based organization want to feed back to each other. We are still actively engaged with several sites that are in the onboarding process. And I just want to note that not all of these sites are funded directly through our SIM grant. We do have SIM-funded sites, and all the basic infrastructure for this pilot and all our IT support is funded through, or most of our IT support is funded through SIM. But we also have sites, e-referral sites, because of the Prevention and Wellness Trust Fund, as well as some of the CDC chronic disease programs that I mentioned earlier. And with that, I want to switch to a quick demonstration where we will be using the e-referral gateway. So I will go here. So in our ideal or gold standard of connection, we actually have the referral leaving the clinical site via the electronic health record. But in this demo, I'm going to first log in as a clinical provider. And so that was our landing page, and now here we are, and it says, "Welcome, Alice." And Alice introduced herself earlier. She's in the room, but she actually does most of these trainings for all of our sites. And so here is what a clinical site would see if they were not using their electronic health record. But they could go in and they could check out the referrals that have been made and the feedback reports that they've received. And so right now, these are all I've clicked on, and these are all different feedback reports that have come back to Alice's account from the different providers. So in this case, we're going to just quickly create a referral, and because I heard something about diabetes, we're going to talk about a diabetes education referral. We can choose the provider. We can enter a name. Everything with asterisks are required fields. So I'm going to quickly type through. Normally we would be requiring phone or some minimal amount of contact information. And you see here we can capture information if it's captured in the electronic health record to send over around race, gender, etc. Translation required was a big one that we heard lots of people talk about. And so this is all the, sorry I'm scrolling, the patient information includes the basic demographic information and contact information, and in the message details are where we get specific referral to referral. And so this is just a general one. Our actual diabetes prevention program one has very specific data elements that are required for patients to enroll into the diabetes prevention program. But here you can get a general idea of what some of the message requirements might be. And these are generally found in the electronic health record. That's how we're able to get it, send a message from the electronic health record. And with that, I'm not going to enter this additional info for purposes of this demonstration, but we're going to send a referral. And it gave me an error because I did not completely fill this out. And likewise, if this is not filled out correctly, it will also get rejected by our system, and then the sending organization will have to fix that in order to have the referral acted upon. And here we see that the referral is being sent, and it has sent, but it has just recently been sent, and it is actually still in our transaction status pending output, or pending being sent out by the system. So the real meat, I think, for purposes of this, though, this presentation is on the community-based organization side, where this is what most of our community-based organizations see. They will be logging in to the eReferral gateway to check on their referrals. In addition to checking on their referrals, they should be receiving email each time a referral is sent into their inbox to let them know that there's new referral activity. And in this case, you can see that there have been 2 referrals sent since July 1st. We have a total of 83 referrals in our inbox, so this can also be a tool used to manage referrals throughout the process of the patient or client being seen by the community-based organization. And so a person can come in, a community health worker or somebody leading a diabetes prevention class, and see all the history of the referrals that have been sent to them. These are all test patients. There is no PHI included in this demonstration. But here we have it since the beginning of this test environment, and this is the one that I just sent. So I can click into view if I'm the community-based organization and I want to see what's happening. I click in and I see that I have a referral from the Massachusetts Primary Care Specialist, and it's to myself. I work at the Massachusetts YMCA, and I even know the provider who sent the actual referral. And so at this point, I can scroll down and get a little bit of information about the patient. I can see if they need, in this case, translation. I know they're here for diabetes education. In most of our diabetes education referrals, we would have a diagnosis code as well, and we might have some different types of progress notes or an A1C as well. And so this system has two different kind of tracks of features at this point. One is for internal note taking. So if I'm at a community-based organization and I'm working with multiple people, or if I just want to use this to keep notes for myself, I can actually take some notes that say, I called this person called, or Laura called and appointment scheduled for 7:20, and I can save this note, and then that shows up at the bottom of the screen. So however many times I'm contacting this person, say I work with several people, and we try not to call people more than 3 or 4 times, whatever our official business process is, we could actually keep track of that. At a certain point, we would hope that the patient was actually enrolling in the program, so we could say patient enrolled and save that note, and now I know that the patient, I didn't say that correctly, patient enrolled, patient in progress, patient enrolled and completed 1 class, next class Sunday, and we can save the note, and again that will be down here, and so we can keep track that way. Depending on what the arrangement has been with the clinical organization will also be getting feedback reports. And so at this point I could create a feedback report to let the clinical organization that I know that I contacted the patient. And so in this case I'm choosing an open referral because the patient has not completed the class. I'm going to say that they're enrolled in the class, and I'm completing this feedback report today. And they've already completed 1 session, and depending on the program, again, you might send back additional information. If it's a diabetes prevention program, you might send back height and weight, or if it's a chronic disease self-management program and there's a set number of sessions, you might just send back the number of sessions. But these are flexible data fields that can be specified based on the referral type. We also allow attachments in certain cases. And so with that, I will send this open feedback report. And so it has been sent successfully. And if it's a little further down the line and the person has completed the program, I might go back and say patient completed. And I know that now that patient's closed out on my side, but I need to make sure that the clinical organization also gets that information. So I will send them a closed feedback report, and I'll say that the patient completed the program and fill out these required fields and send it back. Our pick list of our drop-down list of activity status was based on several interviews with different stakeholders. We are constantly still getting questions or comments, but things to add, and we set up certain rules to ensure that to improve our data quality. But in this case, with a closed referral, we would want to send something back that's a completed program in our ideal scenario, because if a patient's getting referred, we want them to, of course, enroll in the program and complete the program if they're eligible for the program. But we're also able to send back information that says patient refused service or unable to contact patient to the clinical organization. And at that point, the clinical organization can choose to, make outreach to that patient and ask them if there was another service that would be more appropriate, or try and understand if the patient needs additional resources to make that service work. So we can send it back again. And so we have sent feedback reports back. This system also includes functionality for assigning supervisor or role-based delegation. So if you have different referral types coming into your organization, you can designate certain people to only see, say, a diabetes prevention program referral versus a falls prevention referral or a matter of balance referral. And that is to ensure that only the minimum amount of people necessary are seeing patient information or client information. I mentioned earlier that we send over the minimal amount of information needed to act upon a referral, but sometimes that information still includes certain clinical information like lab tests, if it's an A1C for diabetes education or prevention programming, or it might include other hypertension-related diagnoses for chronic disease self-management, but we want to make sure that that information is going to the minimal amount of people who need it to act upon a referral. And so with that, I'm just going to transition quickly back to where we are now in eReferral, and then leave the rest of this open for questions. And we are just really starting to kick off our evaluation now. We're going to be doing a bunch of key informant interviews this summer to figure out what we need to do, especially if we're going to scale up. This is a landscape where a lot of people are looking to push healthcare out of the clinical setting and into some of the community-based organizations, and we are having a increased interest in figuring out how eReferral can be used for referring people both for social support services as well as evidence-based interventions for chronic disease prevention and management. And so as part of that, we're trying to evaluate what we've done well and what we could do better. But one of the first things is that you need both parties or more than one party at the table to talk through eReferral, because it requires understanding on both the clinical side and the community-based organization about what's going to happen after the referral leaves the clinical site, and what the community-based organization's responsibility is in terms of outreach to the patient. We've gotten a lot of inquiries about, referring to food banks or food pantries, which technically the system can do that, but then on the other side of that, somebody has to be there to catch that referral and to respond to that referral at the community-based organization. So it's not a technical limitation. It's a, does this make sense as an eReferral? Along the lines for scaling up, we need some standardization for scaling. There aren't standards that exist like they do for the cancer registry around a lot of our community-based referrals that we're talking about, and so we're really working with our partners on an individual basis. The exception to that has been for the chronic disease work around the diabetes prevention program. That was the first time we started to implement what we felt was a standard. We worked with some subject matter experts around creating a standard, at least for our particular diabetes prevention program efforts here in Massachusetts. And then again, our evaluation, our proposed gold standard was to have electronic referrals leave through the electronic health records and to accept data back into the records, but we know now across 11 implementations that the data that's going back into the record is variable when it's going back into the record at all. And so that leaves some questions for how useful is this for population health management. It still may be useful to connect to the community community-based partnerships, but we were also really looking for this as a way to understand how community-based organizations and programs out in the community can improve population health. So that's something we're hoping to work on this summer and understand both the technical limitations of our implementations so far and why those technical limitations exist. We also want to investigate what referrals work and don't work. We have done different work around referring to visiting nurse associations. We know that the e-referral system, the way it's set up today, is not good for, or not set up for urgent referrals. So referrals that need response within 24 hours. This is not a system. If you need 9 a.m. wound care, that is still a phone call to your DNA. And we're always looking for feedback on additional referral types that we should pursue. This grant was originally written listing specifically VNAs, YMCAs, the Tobacco Quitline, and Elder Service Organizations. That's because the people who wrote it were sitting in a bureau focused on community health and prevention, specifically around chronic disease. So we acknowledged that we had a more narrow viewpoint than if we were sitting in a different bureau, and we're always welcome to hear from people about things that we should think about that are not currently on our list. And with that, I think I'm going to end the presentation there and leave it open for questions. If there are any questions. Let me see if I can see them.
This is Melissa McClung in Denver, and I have a couple questions. Can you hear me?
Yes.
So my first question, on one of your early slides you mentioned that this is open source. Can you talk a little bit more about that?
Right. So because it's open source for a couple of reasons, and Michael, please jump in. One of the reasons is due to the funding source. We needed to develop an open source platform. But the other portion of this is that we really want to get this out there. We're piloting this in Massachusetts. We've been doing this primarily, but not exclusively, in community health centers. We're looking to expand that. But we also know that our experience in Massachusetts is not the rest of the United States. And so we wanted to make something that could be implemented in other states as well.
So that's awesome, and I guess that's more my question. How do we use it? And do you have any documentation around using it?
So we are trying to, we're in conversations with CMS about how this would be, or CMMI I should say, about how this would be distributed. But I think that it's something also that if you are affiliated with a CMMI program, to ask your advisor about that you've attended this webinar and that you have heard about this program and that you're interested in it. But you can also reach out to me, and I can also forward out your specific contact information on as well.
Okay, thank you.
Hi, this is Sissy. I have two questions. So, just tagging on to that open source, obviously this is geared toward Massachusetts. Can a different state, let's say all the barriers move away, can you put in a referral to some entity that's not already in your database? I mean, as you put in something you discover, does that become now part of the permanent database?
Maybe we should talk about the process of onboarding.
Right. So
this is Michael Stelmack. I'm the e-Referral system manager. So I think what's important to try to convey here is the process that we follow for getting healthcare providers and their community-based partners onto the network. So as Lauren mentioned, we have been affiliated with multiple grant funding sources with different priorities. So I'll just offer up as an example our diabetes prevention program, which is a partnership between the healthcare providers and their local YMCAs. So they will submit a grant application or a proposal and get funded by Massachusetts Department of Health, and call out their partnership between the healthcare provider and the YMCA. We'll begin a series of meetings which involve a leadership kickoff to make sure that we share the project and build a shared understanding and perspective on what we'll be doing. Engage the clinical staff as well as the technical IT staff to define a workflow or process for the diabetes prevention program referral. Begin the technical integration work with the EMR system. Begin configuration of the system to support their workflow and the actual data exchange between systems. Provide training, and then onboard them onto the system and enroll them into production and begin the referral process. This can be somewhat complex and lengthy. A really efficient implementation might be as little as 2 months, where we've seen some go as long as 6 or 7 months. It all depends on the readiness of the staff, how straightforward their workflow is, how well established the relationship between the partners it might be, the willingness of the EMR vendor to participate in any technical work or enhancements that may need to be done. So it's somewhat complicated. So for every partner that comes on board, they go through their each unique onboarding process based on what their requirements are.
And I think I just want to say that I think as part of trying to figure out scalability, one of the things that we will be exploring is, is there a statewide standard now for what a DPP referral looks like, and that all the Ys will accept that, all the Ys that run DPP programs or all the community-based organizations that run national diabetes prevention programs accept. But we have not gotten there at this point in time, and that could at least shorten the onboarding process for the community-based organization side. It is still a process on the clinical side for each clinical EHR integration.
Yeah, actually, I think that's a good point. I wasn't quite clear on that point you just made, Laura. And that in the YMCA example, imagine that their first implementation was with provider number 1, and they were brought on board for diabetes prevention program. For every subsequent diabetes prevention program partner, or on the clinical side that they might partner with, on the YMCA side, their work is done. So they can partner with provider 2 and provider 3 and 4, et cetera, and all it means is they'll be getting more referrals to their inbox on the eReferral gateway. There's no more technical integration work for them to do.
Thank you. I had a second question. So I understand this is with SIM grants and so forth, and using the RIOs, which is this is really so cool. This is great. What are your plans, and how are you thinking about being self-sustaining and off the grants, or are you?
There are several conversations going on about sustainability. So right now our SIM grant is actually extended through June of 2018. It was originally supposed to end, I think, in December of 2016, but it's been extended due to the payment reform portion of our SIM grant not progressing as fast. But despite us meeting all of our SIM grant original goals, we are actually continuing on as part of the SIM grant, and have been are able to receive more funding because of the continuation for our specific project, I should say, out of the entirety of Massachusetts budget. there's a couple of ways we're looking at sustainability. One is we are looking with other projects that are occurring within the state of Massachusetts that align with this, and that can be like the CDC grants that I was talking about, where there's an emphasis on bi-directional referrals and community clinical linkages, and we have that infrastructure set up, and so we can align that and focus on whatever the focus is on for that specific grant. In the case of the CDC grants right now, it's diabetes prevention programming. We can look at that for other areas as well. We are also working on sustainability from a legal perspective to enable sites to sign up independent of having a specific project or grant with us, and we've had some of those conversations as well, especially with some of our larger healthcare systems in Massachusetts that would usually not be the recipient of a Department of Public Health grant to do some of this types of programming. We as a Department of Public Health most often work with community health centers and other small providers in maybe rural areas or other things, those types of providers. And we have several large healthcare providers in the Boston area that some of whom have expressed interest in this system, and so we're trying to figure out a way to onboard them. And just with volume, it starts to become more sustainable. We don't know at this point in time if there will be a payment mechanism like there is for our state health information exchange, where different sites have different prices to pay to be part of our health information exchange, or if this will be part of an operational budget or a block grant. But we are having those conversations. We are interested, and I think the department is interested in continuing this past the SIN grant.
Super, thank you.
Hi, this is Lindsay. Oh, hi there. This is Lindsay with Consortium for Older Adult Wellness, and a quick question. You mentioned that the reports back to the referring practices and entities, that some of them were able to go directly into patient data, others had to be entered, and I'm wondering what percentage of uptake have you seen with practices willing to make the changes to have that information go in as searchable data?
We actually have to do an inventory at this point in time. I think it's really low.
It's mixed. It's distinction. Yeah,
well, it depends what data you're talking about.
Yeah, the distinction is that we have many of the EMR systems that are posting the feedback reports in the form of attachments, a Word document or a PDF document. And they're not doing that manually, they're doing that within the system. So the transaction leaves the e-referral system in that format, or is translated to that format at the doorstep of the EMR, and is posted to the patient's chart. So there's no manual intervention, which is good news. The bad news there, though, is our ability to get access to that data in a structured way to do population, data management is very limited. There have been a couple examples, very limited examples, where they have posted some of the data back as structured data, but that's rare today.
What we do think we're going to be able to get, but we're working on it with one of our huge partners here, which I failed to mention earlier, is the Massachusetts League of Community Health Centers, which is our primary care association, and we could have absolutely not done this project without them. They have a data repository and visualization system called Azara Drive, and so they are working to actually map out minimally if a referral was sent from an electronic health record, and if a feedback was received from the e-referral system to close out that referral into their data extracts from Drive. So it would be associated with a specific patient encounter. But again, like Michael was saying, that's really only telling us that a referral was made and that something came back. That something that came back could be that the patient refused service. It doesn't mean that the patient completed the program. What we really would want for population health purposes is to understand if the patient was engaged in the service and potentially how much they were engaged in the service.
Thank you. I appreciate that. That's kind of what we've seen in the work we're doing in Colorado and in a couple of other states. Do you feel, I get the impression though that eventually healthcare, the partners are going to really want that information and be willing to make the investment of time and effort to have that data in a place that they can actually search it and use it. Is that sort of your belief too, or are you hearing differently?
So one of my summer goals, although I'm saying that and it's mid-July, so that makes me anxious, but one of my summer goals is to actually work on this evaluation paper of the technical integration to see why data elements are or are not going back into the electronic health record, because my understanding, and anybody in this room jump in, is that it's not necessarily the healthcare provider or the healthcare organization's decision, but an electronic health record vendor decision or lack of interoperability. There's different ways to phrase that, but basically that the electronic health record is not accepting that information back as structured information into their database. And so what I hope to do, or what we hope to do, is to kind of put that out there for comment, because if we can show that that's been happening across at least the 4 systems that we've currently worked with, and again, these are the 4 systems that we were able to integrate with. We're in conversations or trying to move the needle in conversations around with Epic Ocean and Epic as well. If we can get it out there that we can't get this information back into the system in a usable way, will that change the conversation to allow some of that information back? And I don't know, but that's certainly our goal. We want to see that. I don't know if healthcare providers want to see that.
Yeah. So I'll just add, and I echo Laura's hope that we get moving quickly, because we did. I mean, Laura said a couple of minutes ago, we had talked about just what data is going back into the electronic medical record. That's on our plate in terms of inventory. So looking across our users, who's getting what and who's reading what. So to some extent, whether it's structured or unstructured doesn't matter, because what really matters on the clinical side is how is it used, how is it consumed. And so we want to get a sense not only what's going into the EMR, but who's reading what's going into the EMR and for what purposes. So we're going to learn a little bit, hopefully in the next couple months, about what that looks like. And then, as Laura was saying, the follow-up question is, if it's not as good as you dreamed it would be, why is it not as good? And not to prejudge, but I think somewhere between just what is technically movable within an EMR today in 2016 and how much it costs to move it, and what the demand coming from the clinical health center side is. I think those aren't all aligned yet. I think that's what we're going to see, and that this is where the conversation starts, that clinicians start to recognize where they might be able to see more feedback information. That's going to facilitate the conversation with the EMR vendors about what's feasible and what's cost affordable.
Yeah, I'll just add as a final point, there needs to be enough motivation for the EHR vendors, just as they've done with meaningful use certification, to demonstrate through the certification process that their systems are capable of supporting various clinical indicators and other meaningful use, phase 1, phase 2, phase 3, all the things that everyone's aware of. That hasn't extended into the e-referral domain, and it wasn't a priority, at least not to the extent that we're trying to get it developed. And I think it'll just be a process. If there's enough momentum that's built up through standard setting organizations will build that momentum, and the EHR vendors will have technical specs developed, and will begin to make these changes to their systems.
And we're hoping that payment reform pushes this a little bit too.
Oh, hear, hear. Thank you all.
Hi, this is Melissa, Denver Public Health again. I have just another question. Are you maintaining and collecting information from the community-based organizations, or are they just kind of either they participate or they don't? I'm kind of... Oh, go ahead.
Sorry, continue your question.
I guess I'm just interested in, like, if a program can no longer receive patients, or there's because they're full, or there's other sort of eligibility criteria that needs to be known. Is that something that you get into?
Yes, but not directly through our system. And well, so I have two answers for that, and I'm sure other people in this room have even more answers. But my first answer is that in terms of the capacity to receive referrals, if they have full classes or they lost somebody who was trained to administer a certain program, we expect the community-based organization to be in contact with the clinical organization about not having the capacity to act upon the referrals. Ideally, before referrals are sent over. We also have a TA team in place for all our grant-funded initiatives around this. So the Prevention and Wellness Trust Fund TA should be part of their job is to help facilitate the relationships and partnerships, which would include, helping them communicate on a regular basis if they need that help. I think a lot of our partnerships a lot of our clinical sites do have really healthy relationships with their community-based partners. Often, but not always, they were referring to them in some capacity before. They just never did it through these official means or really had any feedback. The second part to your question, or what I'm going to construe as a second answer to your question, is we have received a request for barriers to care from the community-based organizations. And so one of the things we're trying to implement in some of our feedback reports moving forward is kind of a barriers to care that the community-based organization received. And so that might be something like the person doesn't have transport or child care to the service, or could not afford the service if it's not a subsidized service, or if they have to pay the full price for a particular Y program, or in the case of the VNA, one of our VNA connections, we ran into a lot that the VNA did not have the language capacity, and so they for that particular patient population around diabetes education, and so that connection was not working very well because they didn't have anybody to refer who could provide diabetes education in Haitian Creole. I don't know if that's what you were getting at, but I think it's something we're invested in as a Department of Public Health. I don't know that we're doing it particularly well at this moment in our e-referral system.
No, that's helpful. Thank you. Thank you.
Or rather with our data. It's not a system issue. Are there additional questions? I know we have 3 minutes left.
Hey, Laura, it's Lauren Ambrozic with the Prevention Alliance. I have like a million questions, so I may reach out to you another time. But we've been talking with you over the last couple of years, and I know how much work has gone into this project, and it's really exciting to see your progress, and I just wanted to say congratulations.
Thank you. Yes, yours was one of the names that I recognized during the roll call. So
well, I'll track you down and find Jeff, because certainly not enough time to go into other stuff in 2 minutes, but this was really helpful.
Thank you very much. I'm fine ending on that note. I don't know if Emily or Abby had any final wrap-up comments.
No, just thank you so much. I'm sure there will just be a storm of emails, and thanks for bearing with us with Ready Talk. We'll be sure to make this recording available to a lot of people. We'll definitely keep in touch as all of our efforts move forward. Did you have anything, Abby?
No. Thank you again, Laura.
Thanks.
Thank you very much.
Thank you all for tuning in and listening, because this interest helps keep us going too. So thank you so much.
It's awesome, Laura. Thanks, Abby and Emily, for coordinating.
Thank you.